Καλημέρα σε όλους τους συμμετέχοντες διαδικτυακά στο φετινό Ενδόραμα, καινούργιες πρακτικές λόγω της πανδημίας. Θα προεδρεύσω στο session του Διαβήτη και η πρώτη ομιλήτρια, για να μην της τρώω και το χρόνο, είναι η κυρία Βασιλική Μπράβη, η οποία είναι ενδοκρινολόγος διαβητολόγος και είναι επικεφαλής του τμήματος Διαβήτη στο Imperial College του Λονδίνου. Κυρία Μπράβη, έχετε το λόγο.
Σας ευχαριστώ πάρα πολύ και σας ευχαριστώ πάρα πολύ για την τιμή. Το μόνο που θα με επιτρέψετε είναι, επειδή από τα 18 μέχρι τα 42 μου η επαγγελματική μου γλώσσα είναι τα αγγλικά, πολύ προσεκτικά και αργά θα μιλήσω στα αγγλικά. Και είμαι πολύ χαρούμενη για διακοπές, αν κάποιος δεν καταλαβαίνει κάτι. I'm hoping today to go through a few topics with you. I'm going to start with type 1 and SARS-CoV-2, COVID-19. There has actually been an excellent session on diabetes and COVID-19, so I'm not going to spend a lot of time on this. But I just want to share with you two key publications that came out of NHS England based on the UK's relatively unfortunate experience of the pandemic, as you know, to date. So the first message comes up in the graph on your left-hand side. And that summarizes essentially the epidemiological studies that clearly show that the prevalence of subjects with diabetes, of people with diabetes that are affected by coronavirus, is actually not different from the prevalence of diabetes in the general population. However, on the right-hand side, you can see that diabetes has been identified as a very important risk factor for higher mortality and also higher rate for developing respiratory distress syndrome in patients that get admitted to hospital. So that's message one. Furthermore, we've got national population data here in the UK, both in people with type 1 diabetes and type 2 diabetes, and we link those to mortality data. And those have suggested that in both in type 2 and type 1 diabetes, mortality with coronavirus relates amongst other parameters that you can see here, the two that I have highlighted, BMI and HbA1c. And mortality relates to those risk factors in a U-shaped curve association. So if you're underweight or overweight and obese, or if you have a very low HbA1c or an HbA1c of about 58, you have higher mortality with coronavirus. So clearly our patient cohorts have been affected by this pandemic in a relatively disproportionate manner. Now, the first thing I would like to go through is type 1 diabetes, cardiovascular disease, and complications, a bit of an update here. And I want to highlight that despite the pandemic, there's been amazing pieces of work still in the area of diabetes and type 1 diabetes specifically. Now, we know that the incidence of cardiovascular disease in people with type 1 diabetes is up to 8 times higher than the general population. And there's been a lot of conventional cardiovascular risk factors that have been investigated. So clearly, hyperglycemia is one of them, hypertension is another, hyperlipidemia a third one. And we have learned from studies in type 1 diabetes like the DCCT and the EDIC groups, as well as the UK BDS, that risk engines that are dedicated to assessing cardiovascular risk in people with type 1 diabetes clearly underestimate that risk. And the reason for that is that most of them, for example, the Q-risk-3 score that we use quite widely, they don't take into consideration glycemic control, they don't take into consideration duration of diabetes, they don't take into consideration presence of microvascular complications, so nephropathy, retinopathy, neuropathy. And those facts have revealed a need for studies that cluster risk factors, either negative risk factors or positive risk factors, to try and specify cardiovascular risk stratification in type 1 diabetes much further. Now, this is an observational longitudinal study that has followed up over 8,000 participants with type 1 diabetes in the United States, and it assesses associations between different risk factors and incident cardiovascular disease, so new cases of cardiovascular disease. And what we have seen from this is that the older you get, the greater your BMI, the greater your HbA1c, the greater your systolic or diastolic blood pressure, the greater your lipids load, the greater your duration of diabetes, and the presence specifically of diabetic nephropathy, kidney disease, irrespective of neuropathy or retinopathy, is associated with increased risk factor of cardiovascular disease. And it affects women and men equally. Now, I'm not going to go through that. This is simply to indicate that the blood pressure management recommendations have remained relatively static within the world of diabetes over the last couple of years, and there's a bit of an evolution through the years here. Whilst there is a recent review specifically for lipid management, which I have there at the bottom, with regards to cardiovascular risk reduction in type 1 diabetes, and what that suggests is that individuals with type 1 diabetes are at high risk of cardiovascular disease, high enough from even the age of adolescence. So there's been a relative underestimation of cardiovascular risk and exposure in people that start the diabetes journey in type 1 early. And those individuals need to have a lot of monitoring and consideration of interventions, not simply with statins that bring down LDL, but other agents such as PCSK9 inhibitors that we now use widely from a relatively early age. Now, this is one of the EASD 2020 highlights. So this was presented at EASD last year. And what it has done, it has looked at what we call favorable risk factors in type 1 diabetes. It looks at over 2,000 participants, a relatively young cohort, mean age of 32. And that cohort was from the EuroDiab prospective complication study. What it did, it looked at 7 cardiovascular risk factors, including HbA1c, smoking, BMI, systolic, diastolic blood pressures, LDL cholesterol levels, levels of physical activity and diet. And it scored participants according to the number of risk factors for which they occupied the most favorable tertile. So simple terms, low HbA1c, absence of smoking, normal BMI, normal systolic blood pressure. These are favorable risk factors. And what it did show is that the greater number of favorable cardiovascular risk factors was associated with a lower risk of incident cardiovascular disease in those patients with type 1 diabetes. However, HbA1c always comes on top as a predictive risk factor in cardiovascular disease. So clearly, we never lose sight of glycemic control, which we have to concentrate on early on in the patients that we look after in their journey. Now, when it comes down to mortality specifically, so death in type 1 diabetes, we already know that despite overall mortality in this group of people having reduced, both all-cause mortality and cardiovascular mortality remain much higher than the general population. And we have many studies across the world that tell us that essentially they have an estimated loss of life expectancy of 12 years. They lose 12 years of their life compared to the general population simply by having a diagnosis of type 1 diabetes. And that, for some reason, persists even when we control their cardiovascular factors. So there is a 10-year prospective follow-up of people with type 1 diabetes, and that has shown us that microvascular complication burden, so again, nephropathy, retinopathy, neuropathy, increases in an independent, dose-dependent manner the risk of major cardiovascular events. So if you have those, you have a higher risk of cardiovascular mortality and all-cause death, all-cause mortality. Now, this study was actually presented in BES 2020, and it comes on the background of the knowledge that self-monitoring of blood glucose provides a relatively incomplete picture of glucose control. And we probably have known that for years. So continuous blood monitoring, continuous glucose monitoring, CGM, is thought to give a much more comprehensive picture of glycemic variability, so the ups and downs, as well as what we now call time in range, which has become more of kind of the fashionable and much more the scientific term that we use. We've gone away from glycemic variability and we talk a bit more about time in range. And there are a few studies that examine the relationship between glycemic variability or time in range and chronic complications. Now, here, just over 500 adults with type 1 diabetes from the Belgian real-time CGMS reimbursement program, so a Belgian study, which was an observational cohort study of real-world use of real-time CGM, had their various parameters analyzed in relation to diabetes complications. And there was an association established between different glucometrics in the first couple of weeks of their using CGMS and the presence of diabetes complications. Now, HbA1c and duration, how long they had diabetes, are important risk factors for the development of chronic complications. So they predict chronic complications. Also, what was highlighted here is that a shorter time spent in range between 70 and 130 milligrams per deciliter is associated with several microvascular complications, but specifically retinopathy, so eye disease. So the shorter period of time people spend in range, the more likely they are likely to develop eye disease. Also, time in range was independently associated with being hospitalized for hypoglycemia or ketoacidosis. Now, I'm just going to take a break for people to just stretch their legs and take a little breather. And also we can take, if there are any comments or questions before I move on, just to keep people's attention.
Υπάρχει κάποια ερώτηση που θα μπορούσαμε να κάνουμε στην κυρία Μπράβη για τα δύο θέματα που ανέπτυξε? Δεν υπάρχει τίποτα. Δεν ξέρω αν μπορώ εγώ να σας ρωτήσω εάν τελικά νομίζετε ή από την εμπειρία που έχετε ότι αν πετυχαίνουν οι ασθενείς μας να έχουν μεγάλο time in range, τότε ή αν υπάρχουν κάποιες μελέτες, μόλον ότι αυτό είναι πολύ καινούριο, φαίνεται ότι αν συγκριθούν με άλλους ασθενείς οι οποίοι είχαν πολλαπλές ενέσεις ή απλή αντλία, χωρίς αισθητήρες και παρακολούθηση των ζαχάρων, εάν υπάρχει διαφορά όσον αφορά την αμφιχλωστηροειδοπάθεια.
Ναι, υπάρχει διαφορά και οι ασθενείς οι οποίοι είναι controlled με περισσότερη τεχνολογία nowadays, τα preliminary data και θα τα δείτε στην επόμενη ενότητα, οπότε very well preempted. Τα preliminary data που έχουμε, οι ασθενείς οι οποίοι έχουν επαφή περισσότερο με τεχνολογία και κατ' επέκταση longer time in range, έχουν μικρότερο και incidence και severity of retinopathy. Οπότε πάρα πολύ εύλογο το σχόλιο σας. Absolutely, ναι.
Ωραία. Να προχωρήσουμε τότε στην επόμενη ενότητα, κυρία Μπράβη.
Ωραία. So the previous segment, as I said, leads very nicely to this. Again, it might be the most exciting for clinicians and patients, but actually there's some really good data here to guide us with regards to improved patient care. Now, in the diabetes control and complications trial, so DCCT, we saw that intensive therapy effectively delayed progression to long-term microvascular complications. However, we then have ACCORD, the action to control cardiovascular risk in diabetes, and that shows increased mortality observed in the intensive treatment group, and that was thought to come primarily from high glycemic variability and higher incidence of hypoglycemia. Now, the advancement of continuous glucose monitoring, so CGMS, has enabled patients and healthcare providers to monitor glucose trends for the whole period of a day, for the whole period of a week, for the whole period of a month, for the whole period of a year, which is actually not possible simply by using HbA1c. And that has allowed for the development of some core metrics, one of which is time in range. There's plenty more that complicate, I think, clinician and patient life very much. But essentially, time in range, time above range, and time below range, what we used to call hyperglycemia or hypoglycemia. So amongst those 10 or 12 core metrics, time in range is actually responded to represent overall glycemia better than HbA1c alone. So it's a great ally in looking after patients. So even in patients with the same glycated hemoglobin, HbA1c or mean glucose, the exact glycemic control, as you can see here, may vary. So you can take 10 people with the same HbA1c, but the glucose control at home might be very, very, very different. Now, various evidence supports that time in range is a predictive marker of complications as well as HbA1c, and there is an inverse relationship between HbA1c and time in range. As you can see here on the top figure, that inverse linear relationship between changes in time in range and changes in HbA1c differ according to baseline HbA1c. In the middle figure here, you show that inverse relationship between time in range and mean glucose is preserved only if the glucose values are shifted upwards a bit, between 120 and 200 milligrams per deciliter. And if that falls when glucose levels decrease below 120. In the the bottom figure here, you see that the relationship between time in range and HbA1c differs by percentage of variance. Now, HbA1c has been the only prospectively evaluated tool for us to assess risk of complications in diabetes. But as time in range emerges as a new metric for assessing glycemic control, in addition to HbA1c, there's numerous studies that have reported now time in range as a metric for the correlation with diabetes complications. Now, in view of the current kind of accelerating pace, essentially, of technology, there is a lot more accurate CGM sensors, a lot of novel kind of implantable sensors and devices that can be used up to a period of more than a year by patients. But we have to remember that most of the devices that are still in use are devices that need a lot of calibration. Now, there's been a lot, there's some multiple international diabetes and diabetes education organizations that have come up with endorsing the use of technology with very clear targets as well with regards to glucose levels and how those are controlled. And those glucose levels refer to for type 1 diabetes, type 2 diabetes, but also specifically for type 1 diabetes in pregnancy. Now, automated systems for insulin delivery will become more and more independent, and I'm sure that technology will evolve very, very quickly over the next kind of 5 to 10 years. I think it's almost difficult for us to keep up with that. Now, there are international type 1 diabetes. Apologies. Apologies. Yeah. So there's international type 1 diabetes registries that have shown that HbA1c levels are highest in young people with type 1 diabetes, and improving glycemic control in those patients is actually a big challenge. Now, this is a randomized control crossover trial that included young individuals, 16 to 24 years of age with type 1 diabetes, in whom there was either self-monitor of blood glucose or a use of Dexcom G6 CGM system. And those were compared to see how these patients reached time in range. Now, time in range was actually significantly higher during those that used the CGM technology compared with control. And time above range, as well as HbA1c levels, were actually significantly reduced. Furthermore, hypoglycemia, essentially, so time below range, either for simple hypoglycemia or severe hypoglycemia, was actually relatively low for both groups. So here we see that CGM technology can improve overall time in range and HbA1c for these patients without compromising the risk of hypoglycemia. Now, adolescents and young adults, we said, exhibit the worst glycemic control. So although continuous glucose monitoring has just shown to improve glycemic control, we don't have a benefit overall demonstrated fully in adolescents in a sustained manner. So the previous study was a short study. This study sought to look at 153 adolescents and young adults, randomized them again between CGM and self-monitoring, and followed these patients up for a period of 26 weeks initially and 52 weeks later on. And we see that there was no difference in HbA1c within the period of the 26 weeks initially and the year after in those that were self-monitoring at home. However, there was a statistically significant decrease of 0.4% in HbA1c in those using the continuous glucose monitoring system. Now, this is a study in hypoglycemia in older adults. So this is as well a randomized controlled trial, about 200 adults over the age of 60 with type 1 diabetes, again randomized between continuous glucose monitoring and self-monitoring for a period of 6 months. And what we see here is that the median time with glucose levels that are less than 70 milligrams per deciliter was significantly lower for those using continuous glucose monitoring. And what this shows is that those improvements were regardless of what patients were being treated with, whether those patients were being treated with insulin pumps or whether they were using multiple dose injections in the course of the day. Simply introducing the CGM monitoring technology improved hypoglycemia. Now, this is the Belgian study, the Belgian rescue study, and back in 2018, it reported a significant improvement in HbA1c and in hypoglycemia-related hospitalizations, as well as absence from work for diabetes reasons. So it implied cost-effectiveness when people used continuous glucose monitoring. And after 24 months, HbA1c remained significantly lower compared with baseline and as a function of degree of awareness of hypoglycemia. So in 2018, they reported their initial data, and now they're reporting sustainability data with CGM in that cohort. Now, furthermore, we have sustained improvements in hypoglycemia-related glucose control over 24 months. So not only did patients' HbA1c improve and in a sustained manner over a period of 2 years, but also hypoglycemia reduced, and that was also in a sustained manner over a period of 24 months with continuous glucose monitoring. So here I'm talking a bit about inpatient hypoglycemia and use of technology. Clearly, this is extremely investigational. This is not part of any type of routine practice. And this study is specifically conducted in people with type 1, in patients with type 2 diabetes, type 2 diabetes that were at increased risk of hypoglycemia. What does that mean? These were individuals that had advanced age, so the cutoff was above 65 years of age. They had lower BMIs, potentially underweight. They were taking increased total daily dose of insulin. They might have had a history of renal failure, a history of cerebrovascular or cardiovascular disease, a history of liver disease. So are vulnerable cohorts in inpatients. And what that showed is that in patients where we used, the cohort was randomized between point of care testing, so bedside testing by the nursing staff or the patients, compared with continuous glucose monitoring with telemetry. And they had alarms at about 85 milligrams per deciliter from the telemetry, and that stimulated intervention with a bit of carbohydrate to preempt hypoglycemia. And what that actually showed is a significant reduction of inpatient hypoglycemia when we used CGM technology with telemetry. Now, this is still investigational, but it does really preempt us to think about use of technology in inpatient cohorts who are extremely vulnerable. And I'm not sure about the Greek SC, but here in the NHS, one of the things that the diabetes inpatient service is judged by is incidence of high inpatient hypoglycemia. So it's considered to be a major harm for patients. So we talked a bit about continuous glucose monitoring. How about how about flash glucose monitoring? So flash glucose monitoring, or otherwise known as Libre technology. So the one that patients can intermittently scan at home. That is becoming increasingly used in people with type 1 diabetes. Here in the NHS, we have funding for use in anyone with type 1 diabetes. And it's also becoming relatively trendy amongst younger patients. So this is an Australian study. It randomized some 60 people on insulin that were at high risk of hypoglycemia into either using the Libre technology, the intermittently scanned CGM, or self-monitoring at home. And by the end of a 24-week study period, there was actually no difference in the incidence of severe hypoglycemia, and also no change in HbA1c between the two groups. Now, we have to bear in mind, some people might be aware that there is a couple of studies in the previous 6 months or so, in the previous 2 years, 6-month randomized control trials that have shown very contradicting results. So one showed that we have a bit of improvement in hypoglycemia, but no improvement in HbA1c. The other one showed we had a bit of improvement in HbA1c, no improvement in hypoglycemia. And here we have found no improvement in either. And if we look at the studies have much different designs. So, for example, baseline HbA1c is different completely. There is a median HbA1c of 63 here. There was a median HbA1c of 73. One is a real-world study. Another one is led by very strict clinical visits and clinical investigators' intervention. So there is a lot of study design differences. Hence, I'm not sure that we can draw absolutely specific conclusions. How about flash technology in children? And here, certainly, parents are extremely keen for kids to get access to that. This is another 6-month randomized control parallel arm trial, 64 kids and young adults. Again, we see no evidence of difference between groups for changes in HbA1c at 6 months by using Freestyle Libre versus simply good self-monitoring at home. So the verdict is out here. Now, this is the Corrida study. The Corrida study randomized adults with type 1 diabetes who had good hypoglycemia awareness. So gold scores were below 4. And they randomized them between real-time CGMS or intermittently scanned CGMS, flash technology. And they did it during 2 phases, exercise phase and rest phase, and it aimed a bit to investigate healthy individuals with type 1 diabetes that do exercise. And what it looked at was percentage of time in hypoglycemia or severe hypoglycemia. Hypoglycemia below 70, severe hypoglycemia below 50. What it revealed that time spent in hypoglycemia was actually lower with real-time CGM versus flash monitoring, both for the exercise phase and the home phase or rest phase, particularly at night. Furthermore, the participants that used real-time technology versus flash technology spent more time in range, and that was applicable both to exercise and rest. So there's some indication here that perhaps real-time CGM might be superior to flash technology. Now, this is for anyone who might be further interested. The reference is there, it's also in your packs. This is a position statement that highlights recent advancements in CGM technology specific to exercise. And this is for colleagues that look after perhaps athletes with type 1 diabetes. It's a relatively complicated paper, but it is definitely a very good read. Now, this all brings us to what we call the closed loop control and predictive low glucose suspended systems, which also have attracted a lot of attention and clearly they're currently relatively widely in use in the world of type 1 diabetes. So insulin delivery systems with low glucose suspend features are in clinical use to avoid primarily hypoglycemia, but they have what we call a one-sided action, and they would not really be expected to improve people's time in range or HbA1c. However, we have the closed loop systems now, so the artificial pancreas, as we call it, and they have been developed to improve exactly that, time in range, and at the same time, by improving time in range, improve HbA1c, but not alter hypoglycemia. We want to address hypoglycemia and kill two birds with one stone simultaneously. And here in this study, mean time in range for glucose levels of between 70 and 180, so time in range, increased when we used an artificial pancreas by over 2.5 hours per day compared to simply sensor-augmented pumps, essentially, after a period of 6 months in these participants. We saw also significant reductions in HbA1c based on CGM metrics. And there was also no severe hypoglycemic events. So really, this is a very, very promising technology for clinical outcomes, but also potentially quality of life outcomes for our patients. Now, after the 6-month randomized control trial between the artificial pancreas and PLGS system, the participants were split into two, and they were randomized between closed-loop and PLGS systems. And what we see further down the line, when on follow-up, essentially another 6 months, what we see is that the people that use the artificial pancreas technology have had an even further slight improvement in the parameters of time in range, HbA1c, hypoglycemia incidence. But the people that were previously looked after by artificial pancreas and moved over to PLGS system had went backwards essentially towards their initial values at the beginning of the year. Now, this is artificial pancreas, again, a very challenging technology, very promising for children. This is a 16-week trial. It involves kids of between the ages of 6 and 13 with type 1 diabetes. And these children had already received treatment with insulin for at least a period of 6 months. So they had established type 1 diabetes. And they also needed a minimum daily dose of 10 units. So the reason for this inclusion criteria is that we're kind of phase 3 of developing type 1 diabetes, and truly the pancreas, the beta cells are truly starved of insulin. Now, the glucose level here was in target range for a greater percentage of time when we used closed-loop systems than the children that were using simply sensor-augmented pumps, which is relatively routine currently in kiddies with type 1 diabetes, or sensor-augmented pumps. In the closed-loop group, also the percentage of time that the system, that the kids were in range was not simply better, but it reached up to 93% of the time. Again, without compromising risk of hypoglycemia. So for kids specifically, very, very important messages here. Now, at this point, I will take one more break for people to stretch brains and legs and also come up with any potential questions.
Ευχαριστώ, κυρία Μπράβη. Έχω μια ερώτηση από τον συνάδελφο, τον κύριο Αλουμανή. Θα σας τη διαβάσω όπως την έστειλε στα αγγλικά. What percentage of patients that achieve HbA1c are in fact non-compliant with the TIR targets?
So percentage of patients that don't achieve time in range. That achieve HbA1c.
Are in fact non-compliant with the TI time in range.
Okay, yes. Okay, that's a fantastic question, actually. That's a fantastic question. So you see an HbA1c that essentially reassures you, but that patient has got potentially not enough time spent in range, or potentially quite significant glycemic variability. So I will give you a report of the data that I know well, which is the UK data, which comes from our national audits. So NHS England, so that's national audits here. And it is estimated between 30 and 40%. That is for the UK population. So bear in mind that we have an overall prevalence of diabetes of about 6%, and 10% of those people have got type 1 diabetes. the values I've just quoted for time in range HbA1c is for whole diabetes population. It's not specific to type 1 diabetes. Type 1 diabetes, with regards to our unit, so at Imperial we have some 900 people with type 1 diabetes, and I would say that about 500 of them are well immersed into some type of type 1 diabetes technology. So the data that we had leading up to the conversion of people over to technology, I would say probably closer to 40% for our cohorts. I work at Imperial. It's based between Paddington. I don't know how well you know London, but we have 3 major hospitals, and we're based in areas that are extremely affluent, but also extremely deprived. And we always have to bear that in mind. So deprivation scores. So there might be a bit of skewed data, but certainly time in range has become an exceptionally important tool for us to look after those patients.
Με αυτή τη γνώση που έχετε από την προσωπική σας εμπειρία, ρωτάω εγώ τώρα γιατί δεν υπάρχει άλλη ερώτηση. Άρα στην καθημερινή πράξη πόσο εύκολα πείθετε τους ασθενείς σας, τουλάχιστον αυτούς που έχουν τύπου 1, να φορέσουν το CGMS?
Okay.
Το real time εννοώ, δηλαδή.
Ναι. Το real time CGMS, έχουμε ένα advantage over here και νομίζω ότι το advantage over here, αυτό actually δεν ξέρω αν είμαι accurate, το real time CGMS είναι κάτι το οποίο πρέπει να πληρώσουν οι ασθενείς σας στην Ελλάδα.
Τουλάχιστον για να πάρουν τον αισθητήρα.
Ναι.
Όχι τα εναλλασσόμενα, τα μηνιαία αναλώσιμα.
Ναι. Νομίζω ότι μπορεί να είναι ένα factor αυτό στο αν υπάρχουν διαφορές. Εδώ, anyone with type 1 diabetes is entitled to real-time CGMS for at least a period of time that's judged necessary by their clinicians in 12 months. So, για κάποιο χρονικό διάστημα μέσα στο χρόνο, you're entitled to it. Επίσης, έχουμε το advantage ότι if I judge as a clinician somebody needs real-time CGMS for a prolonged period of time for life, I just do a form for funding, we get the funding, and it's free. Οπότε έχουμε
άρα δεν συνδέεται φορά ή δεν φορά αντλία, κάνει πολλαπλές ενέσεις ή οτιδήποτε. Φτάνει εσείς να μπορείτε να στοιχειοθετήσετε την αναγκαιότητά του.
Absolutely. Οπότε και το compliance νομίζω είναι affected. Στο δικό μας unit συγκεκριμένα έχουμε ένα compliance of about 75 to 80%.
Really high.
Ναι, high. Και νομίζω ότι υπάρχει και το observation ότι those people that perhaps might refuse it are the people that might overall not be as compliant with their care. So these are the factors we need to address. Yeah.
Δεν υπάρχει κάποια άλλη ερώτηση. Νομίζω ότι μπορούμε να προχωρήσουμε.
Lovely. Okay. So, οπότε, moving on στην επόμενη ενότητα, which is type 1 diabetes and pregnancy, briefly. Now, we already know that women with pre-existing diabetes are at an increased risk of severe pregnancy complications. So we're talking about perinatal complications, antenatal complications, stillbirths, and maternal bad outcomes. Now, this study, it was designed in collaboration with the European Medicines Agency. And what it did is it collected real-world data that cover many nationalities. It has broad inclusion criteria. And it looks at over 700 women that received detemir versus 700 women that received other basal insulins that we're very accustomed to using. And essentially, the numbers that you can see on the right get summarized by the statement that in pregnant women with pre-existing diabetes, insulin detemir was not associated with any excess risk of major congenital malformations, perinatal deaths, neonatal deaths, or admissions to the neonatal intensive care unit. So it is actually a really, really nice study that we can definitely apply into our everyday practice. Now, here, I'll try and just summarize some of the latest information that are relevant to our clinical practice. These papers are fantastic. They are in your booklets. There is a lot of overlap with regards to the information. What do we know? Women with type 1 diabetes have a 2.5-fold increased risk of adverse pregnancy outcomes. We said congenital abnormalities, stillbirths, and perinatal mortality. And HbA1c should, and I expect is, measured at the booking visit. So a woman is pregnant, they book their first visit with their clinician, we have to measure their HbA1c at that time. And that is an indication of what was happening with glycemic control pre or periconceptually. It is also at that time a predictor of the adverse outcomes that a woman might come to, and that includes congenital malformations. So an HbA1c which is undesired at the very beginning of pregnancy predicts congenital malformation down the line. Now, in the UK, the National Institute for Health and Care Excellence, or NICE guidance, has joined forces with the ADA, and they both recommend that there should be a target of HbA1c between 6 or 6.5 overall. And in women that are at risk of hypoglycemia or susceptible to hypoglycemia, the target should be less than 7%, so 53 millimoles per mole. And generally speaking, when we effectively manage postprandial glucose, we do much better at getting women to have a successful pregnancy and a successful pregnancy outcome, rather than when we try to control their fasting glucose levels. And generally speaking, we do know from studies that when we have spikes of above 198 milligrams per deciliter, or the 11 millimoles per liter, we know that that's a very strong predictor for big babies, so macrosomia, and complications like shoulder dystocia, etc. Up to 45% of women with type 1 diabetes experienced severe hypoglycemia during pregnancy, and that was about 3 to 5 times more frequent in the first trimester, so in early pregnancy, compared to just the time before pregnancy. Now, I would like to go through very quickly the concept trial. So this is the CGM in pregnant women with type 1 diabetes trial. This randomized over 200 pregnant women, either at the time of preconception or at their early antenatal visits, between the continuous glucose monitoring technology and self-monitoring of blood glucose. And what we saw here is that women with real-time CGM spent more time in range. They had less hyperglycemia, less postprandial hyperglycemia. They had fewer babies that were large. They had lower incidence of hypoglycemia in the babies, neonatal hypoglycemia, and less need for admissions to the neonatal ICU. And if you see the numbers to treat, it's quite impressive. For every 6 pregnant women we treated, we prevented 1 NICU admission, one large baby, and 1 episode of neonatal hypoglycemia. So real-time CGMS seems to improve neonatal health outcomes and potentially lead to a shorter neonatal length of hospital stay. So we have had some preliminary, this hasn't been actually any proper cost-effectiveness studies, they're currently in process, at least here in the UK, about is it worth the spending? So to put somebody on CGMS technology during the pregnancy, it's almost £2,000. Yet if you get them to self-monitor, that's about £600. So it's a considerable amount of money. So from the preliminary data we're getting, I can't tell you, although nothing is published just yet, is that we are saving money by putting women on real-time CGMS. And from the change of the financial year here, so April 2021, every single pregnant woman at a period will be on real-time CGMS during their pregnancy. This is simply to indicate, this is the updated ADA guidance in management of diabetes in pregnancy. The 2 things to highlight is they are including continuous glucose monitoring, although obviously not compulsory. And a relatively recent addition, which actually I think we've been practicing for a while, is pregnant women with pre-existing diabetes go on aspirin at the beginning of the pregnancy. Now, the optimal method actually for monitoring glycemia in pregnant women is still controversial. We haven't proven the point. We've got preliminary indications that are changing our practice so that we can get more and more data. And this actually was published, I think it was earlier this week, actually. I've included it in the talk because it gives us a very important message. So this comes from the chemical pathologists that assist us in the care of type 1 diabetes. And what they essentially have said is, don't forget about HbA1c. So don't forget about the basics. HbA1c still remains the greatest predictor with the greatest prospectively evaluated data to tell us that we change outcomes in pregnant women. We've got a lot of excitement for technology, but the basics we should never, ever, ever forget. It's a fantastic paper because it gives us exactly that message. Now, I'd like to move on for the short period of time that we've got to talk a bit about type 1 diabetes and adjunctive therapies. And the way I'd like to approach this is adjunctive therapies in type 1 diabetes from a kind of cardiovascular and mortality point of view. I mean, why do we want to use drugs in diabetes generally? We want to use drugs in diabetes because we have the proof that they make a difference to our patients' life expectancy, they decrease cardiovascular events, they improve their quality of life. So this is a great review it's a review and an overview of all the studies that we've got available to date with regards to adjunctive therapies and specifically mortality outcomes in type 1 diabetes. And what we know is that what we know from the studies is that in adolescents, what metformin achieved was an initial decrease in use of insulin therapy. So the dose of insulin came down, and also a decrease in the weight gain of those cohorts. That was actually not sustained beyond a period of about 3 months, at least in the studies that we've seen here in the review. So would I consider metformin therapy in a younger individual? I probably would still in the beginning of their treatment, simply because we know that younger adults and adolescents have got a lot of issues about body image, about weight gain, and they frequently manipulate their insulin doses in order to avoid weight gain. So perhaps that is a technique we can use for people that we judge are appropriate. However, we've got the removal study, shows no cardiovascular benefits. And overall, we've got some in vitro studies, in vivo studies actually. So MRI imaging of aortic stiffness, which is used as a biomarker to tell us that potentially there is improvement of insulin sensitivity, but that hasn't been followed up by much more data. So nothing convincing with regards to metformin and type 1 diabetes. How about SGLT2 inhibitors? So SGLT2 inhibitors, as you know, in type 2 diabetes, we've got extensive data and large clinical trials to talk to us about cardiovascular risk in people with type 2 diabetes. It's now, I think the SGLT2 inhibitors now have become the drugs that cardiologists use far more than diabetologists. But when we look at the studies, we've got the PICT on dapagliflozin, EASE in empagliflozin, the in tandem with sotagliflozin, and none of these, actually all of them rather, have failed to prove any cardiovascular benefits in people with type 1 diabetes. Why? Because most of them have not been able to move through the phases of the trials, primarily because of the worries around diabetic ketoacidosis. And certainly we saw that with the canagliflozin study, where there was about 6% of the cohort compared to none in the placebo had diabetic ketoacidosis. So that has been an inhibitory factor to moving along to look at cardiovascular outcomes. And finally, GLP Analog. So again, incretin drugs are believed to have pleiotropic effects. The exact actions in the cardiovascular system, I'm not sure, are exactly well known yet. But there have been some relatively small studies to say that there is potentially a cardiovascular benefit. Nothing is actually proven yet. We don't have any large phase 3 trials to tell us this. So GLP analogs, again, if somebody uses them in type 1 diabetes, we have cohorts of people that have mixed diagnosis or a lot of insulin resistance. Perhaps the choice of the drug fits the phenotype of the patient, but it is not recommended from a cardiovascular outcome point of view for this cohort. Now, the big thing about DKA and SGLT2 inhibitors, this is a meta-analysis, meta-regression, in fact, of randomized controlled trials. It has evaluated SGLT2 inhibitors in type 1 diabetes, and it looks at what things essentially moderate a relative risk of diabetic ketoacidosis. And what it has concluded is that the main things that predict diabetic ketoacidosis in type 1 diabetes with SGLT2 inhibitors is baseline BMI and indicators of insulin resistance, and also total insulin dose reduction compared to baseline, which sometimes is not exactly scientific, but it is estimate. It's a simple estimate. And for the clinicians that do choose to treat some of the patients when they judge it's advantageous for an aspect of care, SGLT2 inhibitors, this is a nice international consensus for those that are interested to read through. But essentially, what does it tell us? It tells us that choose your patients with type 1 extremely carefully, ensure that that the BMIs are not low, ensure that the patients are not catabolic, ensure that they are savvy patients with glucose monitoring themselves, and ensure that they also have knowledge and access to ketone testing, but also go through the sick day rules with them extremely carefully. Now, this is a study in 2020 that looked at short-acting exenatide, mealtime short-acting exenatide in conjunction with insulin therapy. What it tells us is that there is no value from addition of exenatide as an add-on treatment with regards to glycemic control in a patient cohort. So it's a good negative study. And the final kind of adjunctive therapy that has been looked in type 1 diabetes is bypass, gastric bypass. So we think about bypass, we think of type 2 because type 2 is linked to the overweight and obese patient cohorts. However, we do have obese and overweight patient cohorts in type 1 diabetes. And it wanted to look at the long-term benefits and also possible complications from bariatric surgery in patients with type 1. This comes from Sweden. It's linked to Swedish National Diabetes Register. And I think overall the Scandinavian obesity surgery registry, and it's a relatively large cohort over a period of about 6 or 7 years. Those patients were actually prospectively followed up to a period of about 9 years. However, what would otherwise get us excited, things like glycemic control, for example, unfortunately are only reported for some reason due to a lot of missing data up to 2 years, where we see some advantage. But what we do see in the bottom left is that there was an advantage in cardiovascular incidence, specifically in the incidence of stroke and heart failure. So that is something to just keep hold of. That is on follow-up of these cohorts up to 9 years. They certainly benefited from bariatric surgery in terms of cardiovascular outcomes, but I cannot report on HbA1cs. Now, my very last couple of slides are with regards to diabetes prevention and kind of risk stratification, risk of progression. So currently there's huge interest with regards to can we delay type 1 diabetes? Can we risk stratify people that may get type 1 diabetes? Is there any way for us to prevent type 1 diabetes? And there's a lot of activity and a lot of funding from the pediatric type 1 diabetes world with regards to that. Now, this is the TrialNet study that follows children that have positive antibodies. So you get tested, you get screened, you have positive antibodies, you enter the trial. You are the sibling of a child with type 1 diabetes, you get tested, you have antibodies, you enter the trial. The risk of progression to type 1 diabetes in those that have multiple versus just a single antibody, it has not completely and fully been assessed. There is an assumption that if you have multiple antibodies, you have a higher risk of progressing to type 1 diabetes. Now, here we have an analysis of just under 2,000 participants that have multiple antibodies in this cohort. And what we have seen is that age, type of autoantibody, and also your metabolic status all influence the risk of type 1 diabetes progression. Metabolic status meaning BMI. And those that seem to not have one of the most prevalent antibodies, the IA2A, but were GADA positive, which is the most prevalent one, had actually a risk of about 8% of progressing into full-blown diabetes. So again, this tells us be mindful when you know that somebody has got pre-existing antibodies. There is drugs that are coming out to see whether we can preserve beta cell function or whether we can slow down progression. Now, golimumab is actually tumor necrosis factor A human monoclonal antibody. It is specific for TNF-alpha. TNF-alpha we know is a pro-inflammatory cytokine, and it seems to be involved in many autoimmune diseases. And here, what they did, they actually gave golimumab versus placebo to participants that had developed type 1 diabetes. So it's stage 3. So stage 3 is essentially you have type 1 diabetes, you have some beta cell loss, and you are needing insulin therapy. And this was a nice multi-center phase 2 placebo-controlled trial. And it did show that there was a partial remission response in those treated with the drug at the end of the year. And that was judged by the dose of insulin you need for a corresponding HbA1c. So this is a promising agent. This agent is actually going to market in mid-2020, teplizumab. And teplizumab is an anti-CD3 treatment that has previously in vitro shown to potentially reduce beta cell function loss. And what it showed in this study in relatives of people with type 1 diabetes is actually in the people that it got used compared to placebo, it delayed progression to clinical type 1 diabetes in high-risk participants. And it looks as if it may delay the diagnosis up to a period of 3 years. So this is another promising agent that I'm sure we'll all encounter in 2021 and beyond. And at this point, I will come to a close and I will thank you very much for your attention.
Εμείς ευχαριστούμε πολύ, κυρία Μπράβη. Έχω διάφορες ερωτήσεις, οι οποίες ήρθαν τώρα και αναφέρονται λίγο και στα προηγούμενα. Λοιπόν, θα σας τις παρουσιάσω. Εντάξει, νομίζω ότι μπορούμε να έχουμε 5 λεπτά, 6 λεπτά για τις απαντήσεις. Λοιπόν, η πρώτη είναι αν θα σκεφτόσασταν αγωγή με μετφορμίνη σε διαβήτη τύπου 1 και κοίηση περί την 28 με 30 εβδομάδα, αν οι ανάγκες για ινσουλίνη είναι πολύ μεγάλες και η ρύθμιση της αχαρεμίας είναι δύσκολη. Είναι από την κυρία Κούκου.
Ναι, εξαιρετική ερώτηση. Η απάντηση είναι ναι. Και η απάντηση είναι ναι, όχι μόνο μετά φαντάζομαι το reference την 28η εβδομάδα είναι επειδή τότε είναι το oral glucose tolerance test για τις γυναίκες στην κοίηση χωρίς pre-existing διαβήτη για το gestational diabetes. Η απάντηση είναι ναι for gestational diabetes. Η απάντηση είναι ναι και για τύπου α διαβήτη, so pre-existing type 1 diabetes. Και currently we are definitely using that as imperial. Επίσης, μην ξεχνάμε ότι το metformin σε άλλο context τώρα, in the pregnancy context, έχει κάποια καλά data behind it σε σχέση με antenatal outcomes, so baby outcomes, perinatal outcomes. Και αυτό είναι ένα strong indication for use of metformin during pregnancy. So absolutely yes.
Ωραία. Τώρα έχω μία ερώτηση από τον κύριο Μόρτογλου. What is the difference in insulin units per grams of carbohydrates before and during pregnancy?
Εδώ με ρωτάτε κάτι το οποίο θα πρέπει να σας πω ότι δεν είμαι expert, γιατί actually I'm not an expert in diabetes and pregnancy. Όμως, εάν μου στείλετε την ερώτηση στο email γραπτός, I will find the answer και I will give you the answer στις επόμενες ημέρες. Διότι έχω 2 εξαιρετικούς συναδέλφους, diabetes and pregnancy specialists, and they will be able to answer και perhaps give a bit of literature behind it as well.
Θα πρέπει να το συνεννοηθούμε με το γραφείο για να το στείλουμε στον κύριο Μόρτογλου.
Ναι, I will be delighted to.
Έχω κι άλλη μία ερώτηση από την κυρία Πάσκου. Ποια τακτική ακολουθείτε στο Imperial για τη χρήση αντλίας ινσουλίνης στην κοίηση? Μέχρι ποια εβδομάδα κοίησης θα ξεκινούσατε τη χρήση αντλίας εκ νέου ή πρέπει όλες να έχουν εκπαιδευτεί και να ξεκινήσουν αντλία από πριν?
Ναι, okay. Η αγαπημένη μου Λίνα το ρώτησε αυτό. Δεν έχουμε strict cut-off, number one. Obviously, γυναίκες οι οποίες είναι σε αντλία πριν την κοίηση παραμένουν σε αντλία. Έχουμε 2 strong indications για να ξεκινήσουμε αντλία at any point during the course of the pregnancy. Any point. Το πρώτο είναι recurrent or severe hypoglycemia, δηλαδή αν μια γυναίκα έχει πολλές υπογλυκαιμίες ή αν έχει severe hypoglycemia, το severe hypoglycemia το κάνουμε define εάν έχει χρειαστεί third party assistance, δηλαδή ήταν sudden και χρειάστηκε κάποιον άλλο να τη βοηθήσει για να συνέλθει. Και το δεύτερο indication είναι evidence of hypoglycemia unawareness. Αυτά είναι τα 2 strong indications και αυτό είναι για at any time in pregnancy. Απάντησα την ερώτηση, Λίνα.
Τώρα δεν ξέρουμε. Εγώ δεν μπορώ να ξέρω αν την άκουσε ή δεν την άκουσε. Φαντάζομαι ότι θα την άκουσε. Παρακολουθεί. Δεν βλέπω να υπάρχουν άλλες ερωτήσεις. Νομίζω ότι μπορούμε να διακόψουμε εδώ για να μην καθυστερήσουμε υπερβολικά. Να σας ευχαριστήσω πάρα πολύ, κυρία Μπράβη, για την ομιλία.
Εγώ σας ευχαριστώ.
Θα φέρω και τα συγχαρητήρια των συναδέλφων που ρώτησαν, γιατί το γράφουν μέσα. Και ευελπιστούμε να σας δούμε από κοντά κάποια άλλη στιγμή.
Θα το ήθελα πάρα πολύ, κυρία Βλασσοπούλου.
Σας ευχαριστώ
πάρα πολύ.
Να είστε καλά.
Καλή συνέχεια στο συνεδριό μας.
Έγινε. Να είστε καλά. Γεια σας.
Γεια σας. Να είστε καλά.
Και τώρα θα ήθελα, δεν ξέρω αν